We are live. We are live.
Start.
Yeah.
Start.
So, good evening to all my respected members, all seniors, all the speakers from. We're very happy that we have got nice speakers for the evening and panelists from different states even. And I'd like to thank you very thanks. So before we start this program, I'd like to welcome our president, Dr. Simon sir, to give his address. So, Sriman sir, please.
Dear friends, I'll welcome all to the first ever webinar of our ophthalmic society, and it is on the ocular trauma. I welcome again Dr. Ajit Babu Maji, Dr. Kaushik, Dr. Manoj, and Dr. Rajiv, who spared their valuable time for their honor. For last few years, our scientific committee working very hard to improve the scientific activity of our society. They are increasing the scientific work, and they are involving everybody in the scientific activities. Especially, I'll ask Samir, our secretary, who is taking care of the society, and the scientific committee chairman, who is working very hard for last 2 years. I thank both of them, the scientific committee chairman and the secretary. Now this scientific committee chairman, she is giving a new approach to our scientific activity for last few years. I wish all the best for her. And I wish everybody who is working for the webinar all the best. And I thank everybody, those who are participating, the members of OSS. And last but not the least, I thank the executive body who is supporting for the webinar. Thank you very much. Long live OSS.
Thank you, sir. Vidya, Vandate, Amritam webinar series. It is about knowledge leads to eternal bliss. It is here we have tried intergenerational learning. Like Sir Isaac Newton has famously said, if I have seen further, it is by standing on the shoulders of the giants. Each generation of scientists stands on the shoulders of those who came before them, just as the next generation will stand on theirs. This has been paraphrased by many Nobel laureates, including Richard Feynman. Young researchers continue to build upon the wisdom of their predecessors. Like Sir Albert Einstein also has said, young people are the ones who see the possibilities, they dream, they question, they discover. So the curiosity of the young minds, we have taken the youngsters here, who drive innovation and progress in science and medicine. And over to you, Dr. Chittaranjan Mishra, to moderate this session.
Thank you, Dr. Sarmishta Madam, Chairman Scientific Committee of our own OSOS. And again, I welcome all to this webinar. In this webinar, we have a great expert panel, which consists of all the very well-known, renowned ophthalmologists, retinologists of our country of international repute. However, I have the official duty to introduce them. So let me start first with Dr. Ajit Babu Maji sir. So he is someone who is a mentor of the society. People usually mentor people, but he is a mentor of our own OSOS for last probably 20 years. and currently he is the lead of the vitreoretina department at Yashoda Hospital, High Tech City. He is one of the dynamic personalities in ophthalmology, in Indian ophthalmology. So welcome Ajit Babu sir. Then we have Dr. Rajiv Raman sir with us. He is a senior vitreoretina consultant at Sankarnetralaya, Chennai. He is the chairman scientific committee of Asia Pacific Ophthalmic Trauma Society. In addition to that, he is having so many other positions. This is pertinent because this webinar is on posterior segment trauma. He is a great researcher and mentor to many budding ophthalmologists. Welcome, sir, Rajiv Raman sir. Then we have Dr. Manoj Khatri sir. He is the founder and MD of iDocs Hospital in Chennai. He is the head of vitreoretina department in Agrawal Hospital, Chennai. So welcome Manoj Khatri sir. Then last but not the least, our great friend Dr. Kausik Tripathi. He is a senior vitreoretina consultant in ASG Eye Hospital, Kolkata. A great researcher whom I always admire, more than 250 PubMed indexed publications and counting. So along with all our expert panel, we have our OSOS panel, our own Bituretna teachers from our state, Dr. BNR Subudhi sir, Dr. ST Murlidhar sir, Dr. Subhapata Parida madam, Dr. Sangamitra Kanungo madam, Dr. Santosh Kumar Mahapatra sir, Dr. PK Sarma sir, Dr. Umesh Chandra Behra sir, Dr. Jyoti Prakash Behra, Dr. Saswat Behra, and Dr. Sweta Patro. Also, we have all our senior leadership of OSOS, as Madam has already told, Dr. Simon Behera sir, Dr. Sabyasachi Patnaik sir, Dr. Ashok Nanda sir, Samir Patra sir, and myself, Dr. Chittaranjan Mishra, moderating this session from Tirlochan Netralaya, Sambalpur. So, with this, the speakers, we will tell one liner about the speakers just before their speech starts. So in this webinar, let me start with the first talk of this webinar. Let me invite Dr. Brutendu Maharana. Dr. Brutendu is assistant professor at AIMS Bhubaneswar in the ophthalmology department. Dr. Brutendu, kindly share your presentation and start your presentation. Thank you.
Good evening, all. I'll just share the screen. The screen is visible?
Yes, please make it full screen.
Yeah, sure. Okay, it's visible, right?
Yeah.
No issue. Okay. So today I will talk about how to tackle a case of intraocular foreign body. Basically, intraocular foreign body, it occurs after an accidental injury, and most probably it results from a chisel hammer type of injury or a after firearm use. I mean, of course, because of the kind of serious injury it is, it can potentially cause permanent vision loss. And a presence of intraocular foreign body should be correctly diagnosed and treated unless it leads to late complications like siderosis bulbi. And the visual prognosis will depend on the zone of injury, type and size of the foreign body, and any subsequent complications. Now I'll discuss about how to tackle a case of foreign body, and I'll show the videos of different scenarios. Just one small thing about the different kinds of approach. And this is a theoretical about an external approach. If the foreign body is very small, it's a magnetic foreign body and present at the pars plana, it can be tried to be removed through external approach. We can do a localized peritomy, a full thickness sclerotomy. Then using a handheld magnet, that foreign body can be extracted through the choroid. But there are high chances of hemorrhages, vitreous prolapse, retinal incarceration, and failure of extraction of the foreign body if it is large, heavy, and if there is adhesions surrounding the foreign body. So the more popular approach is to do a pars plana vitrectomy and go in and remove the foreign body. Now we usually do a standard 3-port 25 gauge pars plana vitrectomy. We free the intraocular foreign body from all the adhesions surrounding it, so that when you remove the foreign body, there is no traction on the retina. Do the barrage laser to prevent retinal detachment later on. And we have to do a peripheral vitrectomy before foreign body removal, so that there is no unwanted traction to the vitreous. There are many devices like forceps, magnets, and suction tips that can be used to remove the foreign body. We have to, of course, enlarge the sclerotomy route, and we have to be careful to prevent the fall of the foreign body while removing it and damage to the macula or the optic nerve. And subsequently, we can give tamponade, and if required, if there is chances of infection, we can give intravitreal antibiotics also to prevent endophthalmitis. Now, these are various devices for the foreign body removal, like I'll just, yeah, the full screen is visible,
Yes.
or it's showing the presenter's view.
No, it is full screen.
Full screen, yeah, right. Thank you. These are various sizes of magnet, handheld magnet that can be used. This is a foreign body removal forceps. We can see the 3 prongs there. This is a max grip forceps that can be used to remove small foreign bodies, or there can be snares. This can be used to remove irregular foreign bodies. Right. Now we have a few videos. We'll play it. Remove the presenter's view. Right, now it's coming. Okay, now this is a very clean kind of injury. This is the preoperative picture. I'm going to see the foreign body here inferotemporally, and it's a clear media. Okay, now we have started a 25 gauge standard pars plana vitrectomy. Initially, we are doing a core vitrectomy to remove all the vitreouses, and then we do a little bit of peripheral vitrectomy. It's a speed of video, almost 3 times the actual speed of the surgery. Then we free the foreign body from its surrounding attachment. Now here is the foreign body. This was the initial impact site, and the foreign body is rolled to another position. And these are all the vitreous adhesions over the foreign body. Now we are clearing all off. Actually, I always prefer to do a barrage laser before removing the foreign body, because I mean, it seems that while removing the foreign body, if there is kind of retinal traction, if there is subretinal fluid, then there may be a little bit of difficulty in doing the laser. So I usually first do the laser and then remove the foreign body. It's all barrage laser is all done. We do a little bit of cautery on the sclera and do the sclerotomy. Not sclerostomy, sclerotomy. Okay. Scleral cut down. Then we take a max grip forceps and try to remove the foreign body. We picked it up, but it fell down. It fell down at the same place, and we again tried to pick it up. Now it came so nicely. This is the foreign body held with the max grip forceps. We usually use another forceps to widen the lip of this scleral incision site, so that there is no undue traction under it, foreign body, it shouldn't fall down. And this is the post-operative picture, maybe after 3-4 days after the surgery. And the patient recovered well with good visual acuity. Now, this is the second one. Here we picked up the foreign body, but it fell down. Well, trying to pick it up again, we felt that it's getting a little bit difficult. It near the disc, so it may damage the peripapillary area. Therefore, we introduced a magnet and picked it up with the magnet. This is a real-time video. There is no increase in the speed. Here you can see actually there was traumatic cataract, so lensectomy has already been done. So you can see the foreign body here. So introduce another forceps. Hold this foreign body. Because if you try to remove the foreign body with the magnet, it will definitely fall down from the scleral incision site. So we introduce another foreign body forceps that is, it has a very thick tip. All the residents, if they are present, they can see. Nice is easy and out. Now, this is a case of pellet injury. Basically, this happened when, as we can remember, few years back, there was a shooting by the defense people in the Jammu Kashmir. So, there is a patient from Jammu and Kashmir. He has this pellet injury. This pellet is there. It was the primary site where it is impacted. You can see from the shadow. This is a foreign body forceps, but the prongs were smaller than the pellet. The pellet was actually very large, so we couldn't pick it up. And because that pellet, it is globular and smooth, so it is rolling towards the fovea. Even if we take it away from the fovea, it kept rolling there. Now introduced another foreign body forceps. You can see how large this is. Here we had to increase the scleral incision size, because if you make a big scleral incision beforehand, what happens while picking up the foreign body, there will be distortion at the site, and that leads to hypotony. So you make a small incision, pick it up, then enlarge the scleral incision site. And remove it. Okay. How much time is left?
1 minute.
Do I have 3 minutes?
We have to take permission from the expert panel to decrease the. You continue.
Okay. No, I think how much time I took? I think 5-6 minutes. Okay. Now, there are some innovative approaches to removal of foreign body. This is a video I took from the American Academy of Ophthalmology. Video is being made by my teacher actually. They used a silicone suction tip to remove a glass foreign body.
In this
This
video,
is a 2 minutes video, then we'll finish.
Soft tip assisted active aspiration for the retrieval of glass intraocular foreign body from the retinal surface. First case is a 12-year-old girl who sustained injury to her eye followed by a retained glass intraocular foreign body. Firstly, we did a standard 25-gauge pars plana core vitrectomy. Then we initially attempted its removal by the conventional way by use of Macmur's forceps to pick it up from the retinal surface. However, here we can see that the attempts made to grasp the foreign body were unsuccessful, and it could have resulted in retinal injury due to its slippage. At this stage, it was decided to improvise. PFCL have been described in such cases, but the problem with PFCL lies that it takes the foreign body more towards the edge of the eye without solving the basic problem of being unable to grasp the object with the forceps. Alternate suction devices come at a cost and may not always be available. Active suction using silicone tip cannula was tested using objects of various densities, shapes, and materials, including the intraocular lenses. We found this technique to be useful alternative to intraocular forceps because the chances of slippage was lesser once the object is held by adequate suction. The second case is a 25-year-old male who sustained injury to left eye due to trauma, followed by a retained large glass intraocular foreign body. Here, we advanced the soft tip cannula towards the foreign body, and once the tip was touching on the surface, the vacuum was increased to hold it and lift it up from the retinal surface, simultaneously assessing the hold at every moment. It was brought out of the...
Now, all iron, glass, even stone foreign bodies has been removed using this suction method. This is another innovative approach. A nitinol basket forceps is actually used to remove ureteric stone. That has also been used by some authors to remove glass foreign bodies. The take-home message is to do a careful and complete vitrectomy. Now, there are multiple methods of foreign body removal. Use judiciously whatever is available. and the surgeon is comfortable with and without creating much complications. And it's normal for the foreign body to fall, so we should multiple attempts is expected, but let's take care that it doesn't fall on the fovea or the optic disc and cause further damage. Thank you.
Thank you, Dr. Brutendu. Very great videos, and thank you for showing a whole gamut of foreign bodies and different instruments and methods to remove them. So with this, we'll go to the expert panel. My question to Dr. Ajit Babu sir, in the first case, he did not use the handshake technique, like both the hands he did not use, probably it was a fakey kai, but the second case he used that handshake technique. So your tips on removing foreign bodies in fakey kais, if it is a small foreign body, what Dr. Brutendu showed, in fakey kais, really we have a challenge. So your take on that, Dr. Ajit Babu sir. You are muted, sir. You are muted.
For phakic eyes with a small foreign body, there should not be much difficulty. However, larger foreign bodies, you should never think that I will keep the intactness of the crystalline lens. All these larger foreign bodies, the foreign body removal is more important than the status of the phakic clear crystalline lens. In these cases, what we can do is we can do a lensectomy or even extracapsular or FECO and keep the capsule intact.
Yeah,
once
correct.
the foreign body is removed, as a second stage or even as a first stage, you can do the intraocular lens implantation.
Thank you, sir. My second question to you, he has not used PFCL. He got lucky, actually, he removed. So, do you advocate using PFCL in all the cases, or it's a surgeon's discretion on table?
Not all cases, but larger foreign bodies and foreign bodies with sharp edges,
Yeah.
they tend to fall. And if you see the videos, 2-3 foreign bodies, at least 2 times, 3 times it has fallen back.
Yes.
This is a very frequent occurrence. So you need to protect the macular area with PFCL. Some amount of PFCL, not you need not fill the eye with PFCL.
Yes, sir. Thank you, sir. Sir, my second question, my question to the second expert, Dr. Rajiv Raman, sir. He has, Brutindu has told that he does the laser first and then removing the foreign body. So, is it a personalized discretion, or we can do it either way, like removing the foreign body first, then doing the laser around it?
Yeah, I think he did the right thing, and the foreign bodies are usually which are impacted on the retina. When you remove what he rightly said, that sometimes it may bleed so bad that later doing a laser around it becomes impossible. So I think once it's an impacted foreign body, good to laser around it, then make the opening in the capsule and remove, because you will not, you may, if you may still do it later, but if it is a bad bleeding and it becomes a real some large choroidal vessel or retinal vessel rupture, better to do, because it's an attached retina, good idea to do it initially.
Correct. Point well taken, sir. So my second question to you, the pellets that he has shown, and also we have seen in many videos by Dr. Natarajan, sir. So those are really these round foreign bodies. They pose a very big challenge for us.
Correct.
Any special instrument or in technique you want to advocate for these round foreign bodies, circular spherical things?
I think, as you rightly said, these are very smooth, very difficult to remove. Sometimes they fall back. And basket, as I said, as this case he showed, it was really a large foreign body. Basket forceps seems to sometimes work. And one of the tip is that try to these foreign bodies removed from limbus rather than thinking towards removing from the sclerotomy. It's better to remove from the limbus, make a opening there and remove it.
Yeah. So thank you, sir. To continue this discussion to Manoj, sir, my question is, as Rajiv Raman sir has told to remove it through the limbus, do you advocate making a SICS kind of triplanar or biplanar entry, or just one stab entry kind of thing, or any preference? Dr. Manoj, sir?
Yeah, thank you, Chitranjan, for the question, and thank you, Dr. Bhartendu, for wonderful videos. Couple of tricks which you can employ. As Dr. Rajiv sir already said, nowadays we don't prefer a scleral incision due to various reasons. One is hypotony, definitely, and the second is if the choroidal bleed happens, it's difficult to control. So even in phakic patients, what you can do is, even in young patients, what we have done, you do an anterior capsulectomy, eat up the, like you do a phacoemulsification of the nucleus, then you make a posterior capsular excis, lift up the foreign body through the posterior capsular excis, and then take it out from a limbal incision, which is much more controlled because you are going through 23 or 25 gauge vitrectomy system. Two advantages here, you can place a lens into the sulcus or you can place into the bag itself. So that is not a problem. And removal of foreign body is much more controlled. You can do handshake technique and so on. Only one small trick which I will share, which we learned a very hard way. Dr. Rajiv Raman sir will still remember. Whenever you want to lift any foreign body from the retinal surface which is impacted, try to tease it out before removing it out. This is very important. Don't just lift up the foreign body. Otherwise, sometimes you can just lift up the retina itself along with it. So slight teasing of the foreign body, make it slightly loose from the surface, especially from the choroid, and then take it out. So just couple of take-home points. Otherwise, you did
I
a
think-
remarkable job actually.
Just one more add to that, like these spherical foreign bodies, even glass foreign bodies prefer to remove from limbus, because these are the ones, if they break near your sclerotomy or where you are removing from the sclera, it would be very, very difficult removing them. Many times they are fragile pieces of glass and you hold it, and when you're trying to remove, so these are again the ones better to remove from the limbus, sacrifice the lens and then remove it.
Yes.
Yeah, sir. Point
That
well
some
taken.
of the foreign bodies will have some sheath around the foreign body. So ensure that you cut the sheath open
Cut the sheath.
before holding the foreign bodies.
The fibrous capsule, yes, sir.
Yeah.
Yeah.
So yes, with this,
Dr. Chitta, Dr. Sashwat has some questions.
yeah,
Please,
yeah, I have read that. I'll address those definitely.
he
So
can ask.
my second question to Manoj Khatri sir, these glass foreign bodies we are discussing, actually they pose another challenge in addition to the retrieval. They are falling. PFCL sometimes may not help. So any idea of putting visco as a protective posterior pole protection in these eyes with glass foreign body or heavy foreign bodies? Any ideas on that, Dr. Manoj sir?
Yeah, very good point. We have tried everything. Actually, Visco, the problem is with HPMC, it never stays on the macula, it just floats. We have tried Helon, we have tried Viscoat, and so on. So the best way is if it is on the say inferior quadrant or on the nasal quadrant, slight tilting of the globe can help you. Or other way is what you can do is whenever there is a risk of falling, especially the glass foreign body, and especially which is irregular foreign bodies, put a drop of visco, whichever visco you want to use, and then put PFCL on top of that. Then the PFCL doesn't displace us that much. Okay, so that gives
sandwich kind of thing.
Sandwich kind of a technique, but depends on case to case basis. And so like this is what we have learned and we have practiced. In fact, last week I removed one foreign body which was impacted next to the disc on the nasal side. It was quite a severe impaction. We were not able to remove it in one go. It took almost 3 attempts. But again, this teasing helped us a lot. So there was absolutely no bleed, and the patient today after 6 days is having 6/6 vision. So
yeah, sir. The point very well taken. This teasing and what Ajit Babu sir told also, that membrane like something membrane kind of formation happens. So with this, before removal, if you attempt the teasing, it actually helps in this. Thank you, sir. With this, may I move to Dr. Kausik? Actually, two questions by our friend Saswat over here. So he wants to know the tamponade silicone oil versus air, because we could see Dr. Brutendu did very well surgery, and with air also the outcome was good. So what's your take on using silicone oil versus air in these eyes with foreign bodies?
If the retina was on and there is a foreign body, usually the foreign bodies are inferior. So what I usually do is I like obviously laser the retina around the foreign body, take out the foreign body and examine what is there. Like sometimes what happens, like it is bleed everywhere, and it just it is very difficult. Sometimes even RD can happen in such cases, as sir told, if you do not treat the like capsule beforehand, and if you do not tease the foreign body. If it is like very clean surgery like this case, I'll not put it in air. I'll put citrate or SFCs, and it can be done. But if there is a retinal detachment with inferior break or inferior foreign body, which foreign bodies are usually there inferiorly, so I'll put silicone oil. And
Great. So that means little difficult or complicated cases, you will go for silicone oil, and little say simpler cases air. The second question was, in addition to the barrage around the break created by the foreign body, do you always prefer doing a 360-degree barrage, or it's not
no, I
necessary?
don't think it's necessary. If it is a clean case, if you can examine the peripheral retina properly, if vitrectomy has been done, then I don't think there is a need for prophylactic 360 barrage.
My same question to Dr. S.T. Muralidhar sir. Do you advocate doing a 360-degree barrage in these eyes of foreign bodies?
See, that
Dr.
will depend. Yeah, can you hear me?
Yes, sir. Very
Yeah.
well.
You know, if you look at the discussions, it was all about whether it's a small or a medium-sized foreign body. But if you have a foreign body with a lot of vitreous hemorrhage around, and sometimes you think that the only injury is at the point where it has hit, there could be injuries elsewhere. So examination is very important, one. And two is, in some cases, yes, 360 degrees would be beneficial if you have done a complete vitrectomy.
Okay, sir. Thank you very much. That point well taken. Again, another question was to do ILM peeling in these eyes. May I request Subhabata madam to take this question? In this foreign body eyes, in the first stage of surgery, when we are doing, do we do a prophylactic ILM peeling in the fear of ERM formation or something? That's Ashwat is asking. Dr. Subhabata madam. I think madam is not there. Again, S.T. Muralidhar sir, can you take this question, please?
Could you come again? What did you ask?
The prophylactic ILM peeling in these eyes of foreign bodies during surgery.
See, if you have covered the lesion properly and you have not induced any iatrogenic damage anywhere, there's no need to remove the ILM in an attached retina. But if it is a little longer duration and then you are entering in, then it is always a good idea to do the ILM peel. Because immediately, if you are interfering, then the chances of PVR or any of these things are much lesser.
Yes, sir. Point very well taken.
We should go to the next case, I think.
Yeah.
Dr.
Thank you,
Chitra.
madam. Thanks for reminding. So, thank you. We had a very good presentation followed by a very nice discussion, and audience can put their further questions in the chat box. With this, may I request Dr. Ranjita to start her presentation. She is a resident PG student in VSS Medical College, Burla. So, Ranjita, please.
Okay, thank you, sir. Sir, is my slide visible?
Not yet, Ranjita.
Not at
Okay.
Ma'am, can you click on the share screen button, 6 o'clock, green button?
Sir, is it visible?
yeah.
Yes, ma'am. Can you make it full
Make it
screen,
full
please?
screen.
Okay. So, can I start?
Make it full screen, Ranjit.
Yes, is it? Yes, it is full.
It is not full screen.
Not full screen yet.
Click on the full screen now down there.
Sir, is it visible
No,
as a full screen?
it is visible, but not full screen. Down below the full screen icon is there. No, you can click on that.
Yeah, go a little below. Yeah, right.
Is this one?
No. Anybody is there near you, Ranjita?
Doctor, you are stopping the presentation. Don't stop the presentation. Just click on the screen, ma'am. Just share again, please.
Okay.
Yeah, down below there is a full screen icon is there. You can go on to that and click on that. Yeah, down below.
Below there is a minus sign, right? At the bottom of the presentation. एकदम बॉटम में, एकदम राइट हैंड साइड बॉटम में.
Yes.
उसके बाजू वाला जो आइकन है, उसके लेफ्ट next to minus, absolutely next to minus. There is a TV type icon.
There is a TV type of icon, Ranjita. Click
Next
there.
to I minus. Bottom, ma'am. Just bottom. Bottom, ma'am. Next to.
Yeah, go there. She
Yes,
knows. Yeah.
This.
Ranjita, go slowly, right? Slow. Go.
Maybe Chitta, a better choice would be ask her to go on the upper thing.
Upper side, there is a slideshow written.
Go to
the top and slideshow.
Just a sec. Please, there is on the top, there is slideshow written, the menu next to animation.
Yeah.
There, go to that. There you have the slideshow.
So click
on the slideshow.
Just go to the slideshow. Just go to the slideshow option in the top. The menu bar ऊपर जो.
Yes.
Slideshow पे click करिए, please एक बार.
आपका कर्सर नहीं दिख रहा.
Ma'am, your cursor is not going there. Your cursor is in the bottom. Can you move the cursor in the top? Left hand बीच में animation के साथ में जो slideshow लिखा है.
आप you see the home button? Can you see the home button?
Ma'am, can you present it like this only? I think just scroll the slides.
Okay.
Can I present like this?
Doctor, please present like this. I think that's a better option.
Okay. Sorry, I couldn't make it in a proper way. So, can I start?
Yeah, start.
Yes. So, myself, Ranjita, from Bhimsar Bulla. Today, I will be presenting 3 cases of blunt ocular trauma that causes the retinal injury. So, let's start. So my first case is on right eye pseudophakic retinal detachment. So a 50-year-old male worker by occupation presented with the chief complaint of the diminution of vision in the right eye since 2 months, and the diminution of vision was sudden in onset.
Slides are not moving. Ranjita, slides are not moving.
So,
Chitto, you can present yourself now.
Ranjita,
let Ranjita present later on, so that
Yeah.
by that time
Ranjita,
someone
can you
help
send?
her.
Yeah. Ranjita, can you share the slides to Chitranjan so he can play from there and you can just talk?
yes, I will.
You can do that. By the time Chitranjan can present.
Chitta, you can present yours.
Yes, sir. Ranjita, stop sharing.
Yes, sir.
Stop sharing.
Send it to me by email, the PPT by email. Okay. Stop sharing.
Are there any videos, Dr. Ranjita? Do you have any?
Yes, yeah, she's
Yes,
having
sir. Yes, sir.
That will be difficult.
Yeah, then it will be difficult.
So, are my slides moving?
Yeah, we are seeing your slides.
Okay. Thank you, everyone, and sorry for the technical glitch over there. So, myself, Chitranjan Misra, going to present open globe injury with intraocular foreign body, a challenging case. So the case history is like it's a 50-year-old male blacksmith is a nomad. All of us, we would have seen they just travel from places to places. There was a workplace injury to the left eye. He gives the history that while hammering that molten iron, one piece entered inside the eye, and we can see over here there is a corneal self-sealed kind of perforation with iris entry wound, and there is a focal cataract over there. And there is gentle B scan I did, and I could see there is a single mass lesion with moderate to high hyperechogenicity. And with this, I went ahead with the X-ray orbit, and I could see there is definitely a radio opaque foreign body in the both the lateral view and the PA view. So I planned the surgery to remove the intraocular foreign body. So this is the primary surgery for the removal of foreign body. There was mild vitreous hemorrhage. I cleared that. Core vitrectomy, PVD induction. I could see the impact site, some 1 or 2 temporal to the fovea. But when I saw over there, I could not find the intraocular foreign body. I did a 360 barrage. I did the lensectomy as we were discussing in the previous discussion, and I did a no glue, no suture, scleral fixed IOL, and I came out. The intraocular foreign body could not be removed. So it's not a very satisfying surgery, unlike what Dr. Brutendu showed. So the post-op day one anter-segment photo, you can see there are sutures. The cornea wound is very much secured over there. The SFIOL is stable, centered, and we can see in the retro image also. However, it was difficult for me to counsel the patients that the foreign body is still there. I failed in the surgery, and I need something higher, say CT scan, because what was going on in my mind at that time, that the foreign body has actually penetrated the ocular coats. It has gone beyond. That's why I could not see, because I can very well see the impact site, and it was not iatrogenic by me. I was very much sure. So always we see the foreign body cases, they come, the attenders are actually in group. You can see the group of attenders over there, myself explaining to them. And I was telling that I will go for CT scan and possible second surgery. Here also comes a financial challenge. I must tell that these people, they really struggle also financially. So with some generous radiologist with a massively subsidized price, we could do the CT scan. I was intending to see where the foreign body is there outside the coat. But the radiologist told me that, see my dear, it's there still inside the eyeball. So that adds dilemma to me. It is there inside the eyeball. In the impact side, I could not see the foreign body, what to do. Then when I was very much sure from the images that it is there still inside, I did the B scan, and also I saw that it is there somewhere impacted inferiorly inside the cavity. It has not gone beyond the ocular coats. So I took the patient for second surgery, and after the core vitrectomy, you can see something is there. This is what the teasing our expert panel were telling, and there is a kind of cocoon kind of formation is there, what practically they were telling. So I used a magnet over there. You can see the foreign body is coming. It was there inferiorly impacted. Yes, this is the foreign body. Again, I removed it. You can see over there. So post-op 1 month, BCV is 624. Then coming to the discussion, in the case of a posterior segment intraocular foreign body, then I did the literature search, and 21% chance of multiple retinal impact sites are there. If the IOFB is in there in the vitreous cavity, more than one lesion can be there in 8% of the eyes. In the case of a retinal foreign body, more than one impact site in almost 1/3 eyes. So this was actually eye opener for me, that multiple impact sites can be there. And the learning points are CT scan is better than X-ray orbit for radio-opaque foreign bodies. False localizing signs can be misleading in case of multiple impact sites, and multiple impact sites are possible in case of metallic intraocular foreign bodies. And another thing, the subtle part, maybe one emotional part, but the financial affordability for the CT scan remains an inherent challenge for this vulnerable group of patients. They are actually more vulnerable for the trauma. I asked them, do you use the protective glasses? No, they don't use. So this is actually my last slide. With this, I would like to listen from the expert panel, and may I request Saswat to lead the discussion. That will be even better because I am a presenter in this case.
Okay. Thank you, Dr. Mishra. Chitra bhai, have you are you done with your presentation right now?
Yeah, done.
Okay,
So,
yeah, am I audible?
Yes.
Yeah.
You are audible.
Yeah. My question will be to
Dr. Chitto, you can unshare.
Okay.
Yeah. So my question will be to Ajit Babu sir. Sir, like in this case, you saw that there is a cocoon over there. Like how frequently have you seen that? Like it has gone to the depth of the corral and you are not able to remove it. Like sometimes it is gone very deep, then you might not be able to remove it. Sometimes you have to leave it as such.
Yeah, that is not a rarity, but in this case, I would first ask Chitto that
Yes,
he
sir.
could have examined the other areas in the first go itself.
Yeah.
He's very lucky that very small foreign body is there and he escaped. Otherwise, SF5L implantation has been done, which will make the things much more worse when he is intervening second time.
Yeah.
So
So
that
thank you for the question, sir. Actually, when I did the vitrectomy and I saw the impact site, I was not thinking that the foreign body would have ricocheted from the posterior pole to any other place. And yes, what I did not do in the first stage surgery, I did not do a very extensive base dissection. Inferiorly, as I have shown, the vitreous hemorrhage was there. Inferiorly, some vitreous was there thickly adherent. To avoid the inadvertent retinal injury, I did not tease that place much. But then there was the foreign body sitting, which actually ricocheted or rebound from the foreign body. As you told rightly, if I would have poked some more time over there, I could have been lucky. Yes,
the cost of CT also would have been saved.
Yes, sir. But I didn't want to. I was fearing to do a retinal injury. That's
No,
why.
it's always advisable that you should do with depression, and now with wide angle, it's very, very advisable that you can see the foreign bodies in the other places also.
Yes, sir.
Let us then discuss with what Saswat was asking. Actually, it is not a very rarity that there is a full thickness and the foreign body has gone outside the courts of this thing. In that case, you need to see whether it is very posterior or anterior. If it is a anterior foreign body where you think that it has gone through the courts, probably a magnet can help the external foreign body to remove. If it is too posterior and it is near to the macular area, it's always advisable not to further explore.
Sir, like
Because
again,
the damage that can create will be much more traumatizing than leaving the foreign body there.
so my next question will be to Rajiv Raman sir. Sir, in case of like again, I would suppose if we are leaving the foreign body as such, have you seen the development of sidrosis in a case of a deep-seated foreign body like in this? So, and how long usually it takes to develop sidrosis? Like, till now, I have operated only one case of sidrosis in which actually there was pigmentation in the lens, there was detachment. Somehow the patient actually gained vision when I was at LVPI, I did a surgery. Like it was a very typical case of sidrosis. But then when I was searching the literature, usually how long does it take for the sidrosis to develop in these cases? And should we take the help of orbit people to see for the foreign body if it is deep seated in the orbit?
I think what Dr. Ajit rightly said, if it is in the periphery, actually what I do sometimes I use it like when we do a buckle. So if it's in the periphery, you can do external scleral cut down and remove it. So I've removed some of them, localize it exactly like you do a drainage. You can cut on that and remove externally. So periphery is not an issue. You can experiment a lot. But if it's the posterior pole and it is deeply embedded, and rather than creating more problem, you can leave it. Even if you leave it, yes, sidrotic changes may happen. There's the very reason that it is so deep, it would have probably sometimes gone, or it may be more towards the orbit. Retinal injury may be less. Sidrotic changes usually take a couple of years. It's not immediately it will happen. But how much, what we rightly said, whether vision will improve or not, it's important to do a ERG. Because ERG, if you see the B wave amplitude less than 50%, that means still, if it is less than 50% of the other eye, in that case, the visual improvement may not happen much. But if still 30-40% reduction, these are the cases, they definitely improve too much. They improve good vision. And sometimes, again, vision and ERG may not correlate exactly, but that's something you should always, when you have you are suspecting cirrhosis, better to do a ERG.
My last question will be to Dr. Tripathi, Dr. Kaushik Tripathi, sir. Sir, sometimes we have seen that there is a corneal perforation along, and on when we see on the table there is Siddle's negative, which is self-seal. Again, do you go and you repair it, like you put a suture, or you will just see whether it is leaking or not? Because most of us, we actually do try to put a suture and again try to seal it up. What would be your approach?
So basically, when you in such cases, when you are trying to put the probe like trocar and cannula, most likely it will just gape up. So if you, even if you do not put a suture, when you try to do anything, that it will gape up. So it is a better idea, because the thing has gone through this and they are not very clear, like clean, sharp things. They are a little red things. So it is always better to suture this. And because you are put, I am using the wide angle lens. If the cornea or the anterior chamber of cornea is not stable, then it is very difficult to operate. So I think suturing that would be a better idea. And I have some comments for Dr. Chittaranjan. Actually, I think the preoperative ultrasound which he showed, it actually doesn't show the foreign body. It might be a vitreous hemorrhage or something, but that did not have an acoustic shadow. So, and also when the foreign body is not there, you are not finding, most likely it will be inferior. That is for sure. So because it is gravity, it will be around the aura or even pars plana. So as Ajit sir said, it was a good idea to like save the periphery, or at least clear the vitreous hemorrhage as much as possible. May not be in the superior part, definitely, but definitely inferior vitreous hemorrhage has to be cleared if you are not finding a foreign body, because most likely
And
it will be cleared.
another important thing is it may not be only for foreign body. If you have a VITIM trauma cases, there may be a dialysis there, and once you have induced a PVD, he'll come at glass appointment with a closed funnel RD. So I think it's important the moment you are doing a vitrectomy, especially in trauma, you want to see the periphery aura. Even if there is a dense seam, you want to make it sure it is cleared. You want to support with a belt buckle if you have a doubt. You can do laser if required, but you need to, because these are the cases, once you have done a vitrectomy, now it's a fluid filled cavity, and any break, anything will definitely cause a retinal detachment in the next visit.
And also my suggestion would be, like in such cases, you can keep the patient aphakic for now and see how the patient behaves, how vision comes, and then you do the SFL, because it makes indentation.
I agree with you.
Easier.
I agree with you.
So
I had a small comment, Shashwat.
Please, sir.
First component is that doing an X-ray and wanting to plan for a surgery is not a good idea ever. So sometimes at the expense of whatever is the cost or whatever is the thing, it is much better than going in for a second surgery with larger complications as well as what you have induced in the previous one. I think that is very important. The second thing that I would actually always make everybody remember, that even if you have removed one foreign body, you still have to look for more. And I don't think there's any shortcuts in that.
Yeah, so many learning from
And also one suggestion would be go for CT directly. If there is a if you go for CT, there is no need for X, because you cannot process it. It is not possible, and the CT scan will show the exact location, like in the codes. So it also helps you avoid the exposure twice.
So over to Dr. Mishra's.
Yeah, definitely.
Yeah, you can
so
continue.
before going to Ranjita's presentation, she is saying that she will be ready with that. Just to answer few of the comments, it's always the CT scan is the ideal thing, but when the patient did not agree for the financial thing, And in the X-ray, I was seeing only one. That actually prompted me. But yes, I should have done this work pre-operatively, the CT scan by anyhow doing the CT scan. And Dr. Kaushik, he has rightly pointed out the probably it would have been some hemorrhage or something without a backside doing. But that again, that shortcoming was probably because doing a kind of gentle B scan, not to
Open wound. It
Yes.
was an open
Yeah,
wound.
yeah, open globe. That was the reason for finding out. So this and again, Rajiv Raman sir has also rightly told that probably SF5 will doing in the first go was probably overdoing, little more overdoing, because we all know that complications will be really difficult to manage. So knowingly, I showed this case because there were so many points, and also like probably I burnt my finger. So more discussion will be there rather than showing something which is more gratifying result. So thank you all the
Yeah,
experts.
but important thing is the result at the end was good.
Yes,
That is
sir.
most important. Whatever said and done, the patient was benefited at the end. It's
Yes,
all
sir.
because of your hard work.
Yes, sir. Yes, sir. Yes. So thank you, sir. So with this, if there are no more comments on this particular
Yeah,
case, we will
we can go for the next case.
next case. Yeah, Ranjita says that she is ready with her presentation. Ranjita, can you present?
Yes, sir. Can you hear,
Share
sir?
the screen.
Yeah, yeah, yeah.
Yes, okay.
Ranjita, share your slide.
Yes, ma'am. Yes.
Don't get tensed up. Be cool.
Yeah, that is the main reason she is not finding the icons. Don't worry.
In the meantime, can I ask, other than this hammer and chisel type of injury, what other mode of like foreign body injury you all have seen? Like what Dr. Putendu said, like that pellet injury. So what other mode of injuries the panelist have expert panel has seen?
There are so many modes of
So many.
foreign body injuries.
Yeah.
I want to for the general people, sir. I know there is so many road because usually whenever we say foreign body, the hammer and chisel will come into the our mind. And like in Kashmir, there was a pellet injury. A lot of people with pellet injury came.
Uh, I think I can add to that wooden foreign bodies.
Yes.
These are a little tricky ones, and it has to be intervened immediately. The risk of endophthalmitis in these cases are much higher.
So in this OSOS, I presented one foreign body that was actually from the
I saw the video.
use. Yeah, so the foreign body, the protection, so like when kind of the protection that you are using, that itself breaks and goes inside that way.
So I think
So,
one
but
good thing should come, see, for the protection
Caterpillar is
glasses, they
also
should be
another
using the
mode.
polycarbonate glasses. Polycarbonate glasses do crack, but they will not split and they will not hit the eyes. So
these are very
protection.
Caterpillar is another foreign body which is very unique.
Yeah, yes, sir.
Yes, so there was one case of caterpillar hair going into the eye. So there were like 7, 8 caterpillar hair which went into the eye. So how many? Like I think 3 surgeries were done for the patient, and I don't know whether something is left or not. So it keeps on digging inside, inside, and inside. From the outside, it goes inside. So is there any other extra points if you can put for caterpillar hair especially?
Yes,
Dr. Manoj, sir. Manoj, sir, your take on the caterpillar hair induced.
Yeah, very nice question. More than removing the caterpillar hair from the eye, you need to handle the uveitis associated with.
Exactly, sir. There was a lot of reaction.
One is that part. The second is that it's not from my end, sir. I think it's from the presenter Ranjita's end.
There are two devices in the same premise. Please disconnect one. There is an echo coming. Dr. Ranjita, it's yours actually.
The second thing unique about caterpillar type of foreign body, so the caterpillar hair goes inside, not the entire caterpillar. So you need to surge them along the area of pars plana. So you need a good depression, surge them along the area of pars plana. And as you said, these patients with history taking is very important. The second, high index of suspicion. The third, multiple surgeries are very common. In fact, what I have removed two of them. Both patient already had three surgeries. Three vitrectomies already done, but still presenting with repeated vitritis. And also gonioscopy plays a very big part. You may not find a hair in that, but it may sometimes tell you, okay, from where it has entered. So in one patient, we have published it as well, where we found a track where from the foreign body has entered and launched at the area of ciliary body region, just below the pars plana, and be removed through that. So high index of suspicion should be there. Never ever give up history taking, and also careful examination, and then plan for surgery. And I should
think
Chitranjan, for two reasons. One is we know how versatile a surgeon he is, but all of us show good cases. Hardly we will show our complications. So this is one, and two very important takeaway messages. What he has given is missed foreign bodies, which is not very uncommon. Whoever handles foreign body, whether it is in anterior segment or posterior segment or orbit, missed foreign bodies, all of us face. That is one very.
Ranjita, please share your screen while
The
we are
second
discussing.
take-home
You
message what
don't
he has
wait.
given is a deep impacted foreign bodies. You can always revisit your patient. It's not that in the first surgery itself, based on your competence, if you're not able to manage it, even if a posteriorly impacted foreign body, you leave it, wait for 3-4 days, revisit the patient, and you can always do a resurgery if required. So, couple of very good take-home points from Chitranjan's presentation as well. Thank you, Chitranjan, for sharing it.
Thank you, sir. Thank you. Also, the point about the
Chitta,
UV rate is.
I just wanted to make one comment on caterpillar hair and how it can be, visualized preoperatively. UBM could be a good option in one of these cases. And the second thing is anterior segment OCTs nowadays can also actually detect foreign bodies which are traveling in different places, but you have to be a little persistent with them.
Yes, sir. Point well taken. ASOCT and UBM are definitely very helpful for the diagnosis of caterpillar hairs. So, Ranjita, can you please share?
They are trying now.
She has not seen me also.
Can she just read out the case, just a one case as a presentation? If the PPT is not working, just let her read out the case and then we can have a discussion, short discussion on that.
Yes, Rachita, you can only speak as sir said.
No, the pictures will be more better if she can show, because I've seen the presentation. It requires, yes.
We can see.
Yeah, now a full screen, make it full screen.
Go to the above slideshow, click on the slideshow like file, home, insert, draw, design. There is a slideshow above in the upper part.
Slideshow, yeah.
ऊपर जाओ, ऊपर को.
That do not
One,
get
2, 3, 4, 5,
Better if she can send it to
seventh,
someone else.
seventh is slideshow. If you see on the screen.
In the above.
Top
Yeah.
row. Slideshow is there. That is seventh one.
Sir, can she present as it is? Now yes.
Now, Now you the third one. Go to the third. Slideshow. That the icons have appeared. No, you go to the third icon.
You can go to the from beginning. So start with from beginning.
Just unmute yourself first. Please unmute yourself. The other resident, Please close your presentation. Like there is one more resident beside you. Yeah, I think she have to close her presentation and then you show it yours.
You unshared. Okay.
Yeah. Again, yeah. Please share and just there from beginning. Yeah, very nice.
So can I start?
It has not.
It is not full screen now.
Okay,
So
but sir, let
you
her
can present like that also, no problem.
Okay. Start presenting. Yeah.
Yeah.
Okay. Sir, myself, Ranjita Amanatya from Bhimsar Bulla. Today, I will be presenting 3 cases of blunt ocular trauma. Here it goes like this. My first case is about the right eye pseudophakic retinal detachment. 50-year-old male worker by occupation presented with the chief complaint of diminution of vision in the right eye.
Ranjita, go to the next slide. Move your slides.
Yes, I'm moving the slides, ma'am.
No, click on the second slide.
The left, you have the slides number. Go to the second slide.
Second slide.
Click on the second. Yes, 2. Click on the second slide.
This is the second slide, sir.
No, click on the second slide. On the left side, the second slide is there. Just put the cursor over that and click. Yes.
Now, yeah, like that.
Okay.
Just keep the cursor there. Don't move the cursor, so that when you press, it will go to the third slide.
Okay, sir. So can I proceed?
Yes.
Yep.
So my first case is about the right eye pseudophakic retinal detachment. 50-year-old male worker by occupation presented with a chief complaint of diminution of vision in the right eye since 2 months, and the diminution of vision was sudden in onset and was painless and not associated with redness or watering. So his past is suggested that he had a history of injury to the right eye with row 3 years back, and then gradually he developed diminution of vision, for which the patient was operated. And upon ocular examination, his visual acuity in the right eye was hand movement positive, and PR was accurate. And in the left eye, it was 6/36. And intraocular pressure in the right eye was 6 millimeter mercury, and left eye, it was normal. And all of the findings in the right eye were normal except lens. The lens was pseudophakic in the right eye, and in the left eye, it was immature cataract was present. And upon dilated fundoscopy of the right eye, there was retinal detachment with PVR changes seen in the right eye. And in the then we further proceed for the ultrasound biomicroscopy of the right eye, which showed retinal.
Can you tell the grade of the retinal detachment?
Sir.
Grade of PVR.
Sir.
It's okay. Proceed.
It's okay.
Okay, sir. Then we did right eye ultrasound biomicroscopy, which proved that it was a retinal detachment. As we can see in the picture, there was a funnel-shaped retinal detachment, but attached to the optic nerve. And then we did all the routine investigations, that is blood investigation, and then we proceed for the surgical treatment. As we can see in the video. Sir, is it visible?
Yeah, play.
Yes. Then we planned for PPV, and as we can see, PPV is done, and then silicone oil was given under local anesthesia, and the patient was advised for the head down position. And then the post-op day status, coming to the post-op day status in the right eye, the visual acuity was hand movement positive, and the PR was accurate in the post-op day 1. And on the post-op day 2, it was improved to counting finger 3 meter. Then coming to the my next case, that is a case of the right eye vitreous hemorrhage with posterior dislocation of the crystalline lens. 60-year-old male presented with a chief complaint of diminution of vision in the right eye since 2 months, and the diminution of vision was associated with redness and watering. Then upon examination, ocular examination, what we saw that the visual acuity in the right eye was counting finger half meter, and in the left eye it was 6 by 36, and the intraocular pressure was 10 millimeter mercury in the right eye, and in the left eye it was 16 millimeter mercury. And all of the findings were normal except the pupil was dilated and fixed in the right eye, and in the left eye it was circular and reacting to the light, and in the right eye the lens was dislocated, and in the left eye the lens was immature cataract. As we can see the slit lamp picture of the right eye, the dislocated lens was found. Then we did routine investigations.
Ranjita,
Yes,
can you show that slide?
yes, sir.
Because here, will you call this as subluxation or dislocation?
Sir, in the slit lamp, as we can see, and it looks like a subluxation.
Yeah, it's better called as subluxation rather than
Subluxation.
dislocation.
Okay.
No problem.
Then,
Proceed.
yes. Then we did the radiological investigation in the right eye, and the ultrasound biomicroscopy of the right eye, it showed the hyperechoic opacity with the heterogeneity and 50% spike height along with the AC and the vitreous hyperechogenicity, as we can see in this picture, and the presence of oblong clear structures in the vitreous suggestive of the vitreous hemorrhage with posterior dislocation of the crystalline lens.
Is the
Then,
B scan belongs to this patient only?
yes, sir.
Because here the lens is very posterior. If you see
Yes,
the B scan, the lens echoes are in very posterior.
yes, sir.
Sangeeta, how can this happen in the slit lamp? You are seeing like this, and
Yes,
you are doing ultrasound.
subluxation and here. That's
It is
why.
like this. How can this? How is has this happened?
So, because the dilated pupil, we saw
No,
that
patient lying
happens.
down. No, sometimes though the lens might appear in the pupil, but when the patient lies down, if there is the other joints are lost, then it might just hang down. So I think that's was what has happened here. Otherwise, like this
Could
in the
be.
ultrasound, the lens is much posterior in the vitreous cavity.
Yeah.
Yeah,
Proceed.
go ahead. Go ahead.
Please continue. Go
Don't
ahead.
worry. It's only to point out
Okay.
very obvious.
After confirming that it was a vitreous hemorrhage with a posterior dislocation of the crystalline lens, we decided to go for the surgical treatment. As we can see, so as the lens was posteriorly dislocated, it was difficult to extract the lens. Then we planned for pars plana lensectomy with pars plana vitrectomy. As we can see, we're trying to extract the lens, but facing some difficulty to grab it. Then we successfully extracted the lens. Then we close the tunnel or the wound. Then we further proceed the PPB, and membrane peeling was
What is the
done. And
instrument you used for the extraction of the lens?
sir, wire vectors.
Or what you are using for the SICS, that same one?
Yes, sir, wire vectors to extract the lens. Then we did the endo laser and fluid exchange was done, and then on the post of day 3, the visual acuity was counting finger 1 meter, Then coming to my last case, that is a case of the left eye traumatic optic neuropathy. So here it goes like this: 32-year-old male presented with a chief complaint of sudden diminution of vision in the left eye since 12 days after trauma due to the RTA. And the diminution of vision was painless and not associated with watering or redness. Then upon ocular examination, his visual acuity in the right eye was 6/6, and in the left eye was grossly diminished, that is counting finger in close range. Then intraocular pressure in the right eye was 13 millimeter mercury, and in the left eye was 12 millimeter mercury. And in the late and adnexa, there was a suture wound present, and in the the conjunctiva was there was congestion present in the conjunctiva, and the pupil showed the RAPD grade 2, and rest other findings were normal. Upon
What is
examination of,
RAPD grade 2, Ranjita?
sir, like swinging according to swinging torchlight reflex, when we put a light on the affected eye, it will instead of constricting, it will dilate. In grade 2, it will be first constrict and dilate up to not of full dilatation. So,
How do you grade RAPD? Any other
sir,
whatever
there are
technique you have?
there are 4 to 5 grades. First, will constrict and immediately dilate, and
No, sir,
Okay,
then.
no, it's a homework for you. Okay,
Okay, sir.
Ranjita?
Okay, sir.
Okay,
Then,
go ahead.
as we know, the extraocular muscles are mostly affected in the blunt trauma, like lateral rectus palsy or third nerve palsy. So we did the extraocular muscle examination. As we can see, the extraocular muscle was full and free in all directions, that is in 9 gauges. Then we proceed for the radiological investigation. As we can see, the NCCT orbit finding suggested that the altered signal intensity in the left optic nerve, which was due to the effect of the trauma or the optic neuritis. And we did the dilated fundus examination in both eyes, but there was no such changes seen, typical changes seen in the dilated fundus examination. But we suspected it could be the traumatic optic neuropathy, that is which caused the grossly diminution of vision, that is counting finger close range. So immediately we started injection methyl
Any other
prednisone.
investigation would you like to do?
Yes, sir. Yes, sir. Before starting the steroid, we should go for the RBS and blood pressure monitoring. Then, when
The
we saw
ocular
that,
examination, any other
yes,
ocular investigation will you do in this case?
in
Yeah,
this
blood
case,
sugar is good. That IV methylprednisolone you are giving, so you should rule out
yes,
diabetes or uncontrolled blood sugar. I agree with that.
yes, sir.
But what other investigation will you do for the more suspicious optic neuritis or
Yes,
traumatic optic neuropathy? What
yes.
will you do?
Sir, firstly, in the OPD basis, we could go for the color vision testing. In trauma,
Good.
if we suspect traumatic optic neuropathy, then we go for the perimetry, visual field changes, and we can go for the electroretinography. And
What do you expect in electroretinography?
sir, decrease in the B wave,
ERG in
ERG,
optic
ERG,
neuropathy,
ERG, electroretinography.
what will it show? Or something else. For optic neuropathy, what will you do?
So B wave will be amplitude will be low.
Apart from amplitude, there is anything else? Any other parameter you will comment on ERG?
Sir, I can't recall. I will
Don't
read
worry,
about.
you are already under tension. That's why I'm not asking too many questions, but these are simple questions which you should answer. That's why I'm asking. Don't worry. Okay, go ahead.
So we immediately started injection methyl prednisolone 1 gram slow IV OD with 500 ml NS, and injection methyl cobalamin 1500 mg intramuscularly once daily, and injection pantoprazole. Then after giving the after the conservative management, the
Is
post-op
how many days methylprednisolone? The prescription is
so
not complete.
yes sir, it should be given for 3 days ideally, and if not
After 3
improves,
days, what will you do?
after 3 days we will start with the oral prednisolone if the vision doesn't improve.
If it improves,
We can taper the steroid.
So read about the ONTT
No.
trial and guidelines. How did
Yes.
ONTT trial में कैसे
It's okay.
हुआ पढ़ लेना.
Chito, you can discuss now.
Yes, sir. Of your presentation, Ranjita.
Yes, sir. Okay.
Okay. So thank you. First of all, I must congratulate Ranjita. Under a very stressful conditions, he has actually
Yes,
presented it
yes.
less than Hardik Pandya bowling the last over in the T20 final against South Africa. So she has done a good work. Let us congratulate her. She has presented actually three cases. One was traumatic RD. The second one was removal of a traumatic subluxated or dislocated cataractus lens, and the third one was on traumatic optic neuropathy. So let me come to Dr. Santosh Mahapatra. Santosh Bhai was there. I think I saw him briefly.
Yeah.
If he is there, can he take the question of management of traumatic retinal detachment? Any difference from any routine retinal detachment management? Santosh Bhai, are you there?
No.
Okay. If not, Dr. Jyoti Prakash Behera, he is there. Can you take this question, please?
Jyoti Prakash is there. Yes.
Yes, yes. Can you repeat the question, please, Dr. Chitra?
Yeah. So my question is, in a case of traumatic retinal detachment, the management of it is different from a conventional retinal detachment management, or it's the same? If it is different, in what ways?
In traumatic retinal detachment, I think management is more or less same according to the site of the injury. Like if you get a traumatic retinal dialysis, so as you treat the dialysis, you can do a external buckling without going for a vitrectomy. And in dialysis, we can use that convex type of buckle, which will hold the dialysis part. And if there is retinal breaks without any complications, without any PVR changes, we can go for a external buckling with 276 or 277 type of buckle. And and except because going inside in a traumatic cases, it's still all the traumatic cases are prone for infections. So I think going externally whenever is possible is a better option. And if there is PVR changes, we need to go inside and do a vitrectomy and do the manage the retinal treatment as usual.
Okay, so thank you. Dr. Jyoti Prakash has told about the closed globe injury cases. So may I ask Dr. Rajiv Raman sir to explain or like his views on the open globe injury associated with retinal detachment, the management of RD in these cases, and any addition to Dr. Jyoti Prakash's views. Dr. Rajiv Raman sir.
Yeah,
Yes, sir.
so Dr. Jyoti Prakash, what he said was some ways correct, that these are, as far as management it is, but the detachment is quite different, the traumatic detachments, because these are the cases where you have all the ingredients of a severe PVR. So you have break, you have lot of heme, and they are young people. So these cases, they have extensive PVR and they develop PVR pretty early. So that is one part. young patients, usually they don't have a PVD, as he said rightly, that if it's a peripheral break without PVR, buckle is something you can still get away with. But if it is, you have to go inside, that you do a complete job. As far as open globe is concerned, when it is a trauma, when there is a penetrating injury and there is an open globe associated with retinal detachment, the first aim is, again, these are the ones where you have gray zones. Don't try to do the retinal detachment surgery at the primary sitting. You want to close the globe first, wait for about a week. That time, except of only two situations, endophthalmitis and intraocular foreign body. These are the two things where you want to deal both the things at the time of primary repair. All others, probably about a week when PVD also starts to induce. These are again the cases where choroid is also thick, you have choroidal detachment. So as it's not like any other retinal detachment. These are the cases where you have many other concomitant injury which are there. And you may have everything fine, but there is a photoreceptor loss, a type of a Berlin's edema, or there may be associated optic nerve injury. So usually these cases you need to take a very holistic approach. Never talk about prognosis, because many times it's not like your adult retinal detachment which will do very well.
Yeah.
Dr. Ajit, you want to add anything? Please.
Yeah,
Yes.
if it is open globe injuries, it's always better to do the belt buckle at the primary sitting with the closure of the ocular codes. I would say ocular codes because it can be cornea or is scleral. It's always give better to give the belt in the primary repair itself. And the intervention should be 2 weeks because most of the vitreous separation and PVD occurs around 10 to 15 days or
Correct.
20 days.
Correct.
So you need to go for the second week rather than first week, unless there is a intraocular infection is there. Okay.
So as we
I
go,
just I
yes.
just wanted to add one more thing. In the intervening period, if you have an open globe injury and you have to do it a little later, I think if you have done a primary closure, you should also think about systemic antibiotics. I just wanted to know the view from the others.
Can Ajit Babu sir or
I fully agree with you. Whenever there is a open globe, usually we give a antibiotic, systemic intravenous antibiotic
Yeah,
coverage. It's always good because it's there that once there is an open globe, you treat it like there is an infection.
exactly.
Unless you know, it's very difficult. It may not present initially, but probably next 1 or 2 days he may come with endophthalmitis.
Yeah.
So that's the reason it's always important to start on antibiotic,
And
intravenous antibiotic.
intraocular antibiotics, you should be very careful
Yeah,
unless
we
Can
the
don't get
globe
induce,
that.
is very well
should
formed.
not. Yeah,
Should
Correct,
avoid
correct.
intravitreal antibiotics at the primary
antibiotics,
sitting. Once the globe forms, immediately you give the intravitreal
intravitreal.
antibiotics. That
Yes, sir.
observation should be careful about.
Correct.
So definitely the point well taken, and what I again emphasize from all our experts that we should go for a stage surgery rather than a one-time done and finish kind of surgery. We should first manage the impact of the wound first. Then after 1 week or 2 week, go for the early surgery repair. So thank you for
There's
that.
there's one more thing. I think age of the patient is also very important if you are looking at these things. Younger patients or children actually behave differently in cases of RD and with the PVR. They totally like behave very erratically.
Yeah.
Anybody wants to make a comment?
The
Could you
effect
hear?
of that is
Yeah,
yes,
yeah,
yes.
we can hear, but it's okay.
Okay. So, with this, may I ask the next question to Dr. Manoj Khatri sir? All of us, we have been taught that even no PL is not a contraindication for surgery in trauma cases. All of us know how excellent in surgical prowess all the experts are over here. My question is that any particular case where we will not wish to operate on, it's something contradictory. So any case is there, or every case we should go for surgery?
At least give it an attempt. At least give it an attempt. So, most often or not, as you rightly said in your question itself, they are unpredictable. So even sometimes NPLIs, we are able to salvage some anatomical and functional restoration. So never give up in trauma, and most often or not, trauma happens in the working age population, what we have seen, or pediatric age group. So you should always try. I will
Now,
also.
first of all, we should I want to affirm that NPL recorded by someone is not at all be taken. High intensity indirect ophthalmoscopic light should be used to check whether the appreciation is there or not. That is number one. Most of the time people record NPL and I see it is PR accurate. So that is number one thing, you reconfirm whether it is really PL negative or not. If it is PL negative, the next investigation that need to be done is VEP. Wave pattern is there means the potential will be there, visual recovery potential. Unless it is grossly mutilated, every trauma eye should be repaired. This is
The point, yeah, the message is very loud and clear from all the experts that we must not abandon these eyes or put in the basket of EBC retinal.
I would invite the opinion. Hello, Dr. Chitra.
Yes, please.
Yes, I would invite the opinion about the case regarding whether we should operate every trauma case or not. So I had a case, a traumatic blunt trauma of closed globe injury, where there was a HST in the inferior sector, and the RD was a localized RD, and it not reaching the inferior arcade also. So, and the vision, the more important, the vision was 6/6. So, but there was a RD, but as the vision was 6/6, and it was a trauma case, I decided to barrage the RD, and still now it is holding on. The barrage is holding on over 3 months after injury, and vision is still maintained 6/6. So whether we should go for a surgery in these cases or not.
You are talking about case of a localized chronic RD where a barrage is possible and the vision was good, and that there is no PVD happened. Actually, you are lucky in this case, the PVD has not happened. That's what your complete PVD has not happened. That's what the RD has not progressed. So in this case, we will not operate unless until there is signs of hypotony. In these cases, long time we have seen the IOP remains normal, but sometimes the chronic seepage of fluid can lead to hypotony, and then in those scenarios you will try to intervene. But otherwise, I think in your case, straightforward, no, not an indication for surgery.
Thank you, sir.
So
I think
with this,
inferior RD is something because of that it is holding on. It's an inferior RD localized. Localized again is a very vague thing. Classically, we describe as subclinical RD when it is about 2 disc diameter. So anything more than that, there is no harm supporting with a buckle. It's not only hypotony; they'll come with a chronic inflammation. Vision will be 6/6, but every few days she'll have pain, redness in the eye
Most often are
because
not
the
these
detached
are
retina. Yeah.
most often or not, these are incidental findings as well. Patient had a history of trauma, and you see, like when you ask it retrospectively, then they will say, yes, I had a trauma.
Yeah.
So, as Dr. Rajiv already said, inflammation, low grade inflammation, and no harm in putting a buckle to support that.
Buckle there. Yeah. Yeah.
I have a query here. So post RD, suppose a vitrectomized eye develops a localized RD, suppose beyond the Barrett scars, sometimes
Go
it
back.
develops NVI and NVG in aphakic cases. But do patients with localized RD non-vitrectomized ever develop NVI or NVG if it is more than 4 DDs or so?
100% they will develop. I have even a case which has developed who has developed vasoproliferative tumor. So I have a patient coming from Sri Lanka having exactly what she said, barrage, and beyond that there is a retinal detachment, 6/6 vision, and people have been treating every time with anti-VEGF because it has a tumor, a peripheral, one which is bleeding also many times. So that's something they do present. So if there is a doubt, better to go ahead and attach that, because that's that detached retina which is causing all the problems.
So again, what we read,
may I add? Actually, we did fluorescein angiography, ultra-wide field fluorescein angiography in retinal detachment cases, and we saw that old retinal detachments had peripheral capillary perfusion area and also new vessels. So peripheral chronic retinal detachments will have peripheral ischemia, and then can cause new vessels in the retina and also new vessels in the iris. So if any RT which is more than subclinical, it is better to support it with a buckle or do PPV, because even though vision is remaining 6/6, it might not remain for a long time, and the NVI, NVG, etc. can happen, or recurrent inflammation can cause a problem.
So if I extend this question, like we have done a barrage, there is the anterior retina is detached from that part. The posterior part is very well attached over there. So during siliconal removal, it says siliconal field eye. During siliconal removal, will we prefer to cut that retina to prevent the ischemia? But that comes at the cost of more pigment release and PVR formation, or we'll just leave it as such. Any of the expert panel can take this question. It's a big one, not very small, like quite a kind of anterior to the barrage.
So if there is no tractional element there, it's just a mobile retina, attach it. But if it's a stiff retina where you know this will not go back, it's better to cut it and do a laser. You'll definitely do a better job rather than just leaving it. So if it is something which is mobile, you know there is no tractional element there, not stiff retina, you can attach that and do a good barrage, good laser on the buckle along with it.
Great. So point is very well taken.
Yeah,
It depends.
I think, yeah, go ahead, say. And see, my point is very simple. It's like the flap that you have, a large flap anteriorly of a retina, and you don't remove that, you are bound to get, problems, including NVG.
Yeah.
So it's always advisable that, you have to treat it in terms of a free flap kind of a thing, which is floating. So just remove that entire retina and then do the barrage laser all around.
Yeah.
Almost like you treated GRT.
GRT, exactly.
Yeah.
Point is very well taken. So my next question is to Dr. Shweta Patro. She is over here. Regarding the second case, Ranjita told that they planned PPV and PPL, pars plana lensectomy, but they ended up in removing it through the tunnel, kind of cataract extraction. So your take on that, when which one you prefer, or any specific biomarkers or conditions where you prefer a cataract extraction like a SICS own tunnel through that, or a PPL for a subluxated?
So whenever, can you?
Yeah, proceed.
So basically, my point would be glaucoma. If there is glaucoma, I always prefer to go with a fragmentum. I would like to save the superior part of the sclera, so there is some space for trap if the patient if the patient needs in future. So and the iris, if the iris is not traumatized and the pupil is well dilated, if the cataract is hard, I can try to remove it through a SICS tunnel if the glaucoma, there is no rise in IOP. But I normally prefer to do it with a fragmentum because it keeps the case very neat. And future, like for glaucoma surgery, it is preferable. Like I feel it is have better prognosis with that.
You are muted, Chinto.
Yes, sir. Sorry. If at all we are removing it from the SICS tunnel as they did in the surgery, how many of us are in the advocacy of putting visco for the protection of endothelium? I am asking this because the infusion is on and whatever we put actually comes out. So the importance of putting visco in these eyes, if at all we are removing through the anterior route, the lens.
No, visco doesn't stay.
Doesn't stay. So.
Vision doesn't stay.
Usually.
Yeah, Dr. Kaushik.
I personally don't put.
No, visco will not stay. And another thing, I think in this case, because the lens was dropped early, and I'm not sure of the vitrectomy which has been done, might be a risky idea to take the thing out in the anterior.
Expulsive.
experts.
No, mainly they don't have the frag. That's why they probably attempted this. That's why I didn't comment about it.
Yes, it might be.
It is
Could they not remove?
always easy that we don't have the equipment, then it's bigger trouble.
Yeah.
I would rather ask a question that if you are using a wire vitreous and you have not managed the vitreous properly, what are the risks?
Yes.
Yeah. Consequences.
Yes, that need to be told to them so that they will be much more careful.
So
I had also a question that did they try with the vitrectomy cutter if they could remove that? Because if you look at their ultrasound and what they were talking about and the lens density that we were looking, probably the vitrectomy cutter could have also helped them.
removal of the
Maybe
vitreous.
because see, you should also see the longevity of the vitreous cutters.
Yeah.
Probably you may require two or three cutters.
Possible.
It's not that we have not done all that.
Okay. So with this, if you move to the third case by Ranjita regarding the traumatic optic neuropathy, we all had a very good discussion, and this will definitely help in the exam for all the residents, not only Ranjita, all the residents who are attending. So my question to Dr. Kaushik is that in addition to the color vision and the electrophysiology that has been told, one thing was missing actually the fundus examination. She did
Yes.
not comment.
He told, no, she told that it was not written on the file. That I was wanting to tell that you need to mention the optic disc and the fundus in the list only. The list did not contain that, but she told that we did not find any typical finding of optic neuritis, traumatic optic neuropathy. So my next question was, what would be the typical finding of traumatic optic neuritis?
Many times you see the optic nerve as normal, isn't it?
Usually it will be normal. Usually
Usually, yeah.
visible only except the RAPD and poor vision.
Yeah.
So that is the typical finding.
Yeah. Any role of contrast sensitivity, Dr. Kaushik?
Actually, in such a poor vision, it is very difficult to do. But and I had some comments from for Dr. Ranjita. Actually, she was very stressed, but she presented very nicely. Excellent. By actually, in such a case, so many seniors are there. We also have been through this. She actually presented very.
Yeah, she joined very early. She tried with her slides. I don't know what went wrong later on.
But my suggestion would be when you are writing the slides, you do not write small abbreviations, and there were grammatical mistakes also in the slide. So because many seniors are there, you have to mention it fully. Do not there spaces were somewhere not there, abbreviations. There should be no abbreviations, or if there are abbreviations, they should be accepted, well accepted abbreviations should be used. And also in optic neuropathy cases, you have to mention the projection of rays here. So make a habit to write projection of rays in all cases. And also in the list, you have to mention the fundus. That was not there. So these are the things. And as Ajit sir also told, read about what the management. You wrote IBMP 1 gram, but how long would you give it? And what investigations did you do before that? That should be when you're managing the case, you need to write them, mention the investigations also. I did when blood sugar was this, and whatever is you have done. So that shows that yes, you have done due diligence before treating that, and you know that yes, I need to do these things at least before starting the patient. And also the ERG question. So you'll have to read what is the electrophysiological test of choice to in optic neuropathy cases. So you did very good, and it was excellent. Just these are some pointers. Thank you.
Great. So again on traumatic optic neuropathy, to continue with this steroid thing, my question to all the expert panel, starting from Dr. Manoj, the IV methyl prednisolone 1 gram that we are giving in traumatic optic neuropathy cases, is it a norm or it depends on the physician's discretion? To all the experts, like Dr. Manoj, because we all know that it's added prognosis. Yeah.
I think you are leaving all difficult questions to me or controversial questions.
Sir.
Okay. I think it's more than a norm. It's I will not even say by default, but the practice goes like that. Traumatic optic neuropathy. We are desperate something to be done, and we also know that the time is very critical here. So in some cases where we have not given, we later on realize, or at least we should have given it a try of 5-methylprednisolone, whether it is 500 or 1 milligram, 1 gram, sorry. So depends, but most of us are not, we earn on the side of treating the patient rather than not treating the patient. On this, I think we have a documented evidence where optical avulsion has been there, whether it is on a clinical examination or on a CT finding, or whether there is a bony impingement. So nowadays, a lot of, I will say, investigative technologies have evolved over a period of time. Case-to-case based discussion should be there. But if it is a straightforward, proper traumatic optic neuropathy without any mechanical compression, I will still like to give IV Minty for the patient.
Yes, point is very well taken. So, in addition to these small exceptions that you told, Dr. Kaushik, do you consider the crash study like the multi-trauma
Yes,
with
yes.
spinal or bleeding?
I was going to tell that, but that did not show any benefit. But in private practice, I think I have given all cases of traumatic optic neuropathy. I have tried. Why not give a chance? Like it is like why should I give up when the patient is presenting with no PL?
Where we have missed out, and then we later we regret, okay, we should have given at least a chance. You should have given out, especially in young patients. So we always say. And also, traumatic optic neuropathy, I've also learned one more thing, like, we often ignore examination of the other eye, and we also ignore examination of the other major injuries to the patient. So, couple of cases which we have burnt our fingers 3-4 times where clinically we have missed out, gross injuries to the other areas, including intracranial injuries. So, all these things also should be kept in mind rather than just concentrating only on the traumatic optic neuropathy.
So, thank you all the expert panel. Before I hand over to our chairman scientific committee, I'll just wrap it up in less than 1 minute. Dr. Britendu presented many varieties of injuries with many number of instruments to retrieve the foreign bodies. And myself presented a case where the role of CT scan was very much necessary over X-ray, and a proper B scan is needed over there, and multiple impact sites of intraocular foreign body, especially the inferior part, with a proper base dissection. The importance of that was emphasized in the discussion. Ranjita presented 3 cases where we discussed very nicely and listened to the experts on the views and the detachment management in a case of trauma, and then the extraction of a traumatic subluxated cataract, and also traumatic optic neuropathy we discussed in detail. So thank you all the expert panel, and now I hand over this to our chairman scientific committee, Dr. Sarmista Madam.
Thank you, Dr. Chitta. With the permission of the expert panel, can we ask the sponsor to show their video, sir?
Sure, madam, sure.
Mr. Sunil, can you please go on with your video?
Mine is blocked. For streaming purposes, my video is blocked.
Okay then.
You given the chance, they have not utilized. It's fine. Now you can give the vote of thanks.
So I take this opportunity to thank one and all. Thank you all expert panel. Thank you sirs for your valuable time spent with us and all the valuable suggestions. Thank you Osos panel, all those who were there. And thank you all the speakers and all the participants who are there watching it live in Facebook, in Weblink and all. And thank you Entod for the platform. Thank you one and all.
Before we disperse, a special thank to Sharmista Madam to stitching this together. Not many states come forward to do a dedicated webinar only on ocular trauma, and also charting it out so well and giving constant reminders. Hats off to you, Madam, and your thought process.
Thank you, sir. I thought I'm bothering you lots more.
No. Very, very meticulously planned, Madam, and so much to learn from you, actually.
Thank you so much.
Thank you, Madam.
Thank you.